Well, first of all, yes, we are going to discuss the treatment, systemic treatment in NETs and NECs, which is completely different. So starting with NETs, there are an increasing number of treatment options for our patients. Not very many still, but they have grown substantially in the past decade. And this includes somatostatin analogues, somatostatin receptor targeted radiopharmaceuticals, and angiogenesis inhibitors, and mTOR inhibitors, and of course chemotherapy. And we have recently incorporated a new angiogenesis inhibitor such as cabozantinib in the refractory or pre-treated setting. And but the options differ by primary treatment site. The pancreatic NETs are the ones that have all the options. GI NETs have only somatostatin analogues, lutetium, dotatate, everolimus, and cabozantinib, and then lung primary NETs have only everolimus and cabozantinib as approved treatment options. So we have all these options, but the optimal sequence is really not clear. We're going to discuss a little bit what are the factors that influence our choices. It's true that we have now a few head-to-head randomized trials comparing basically either lutetium dotatate with high doses of somatostatin analogues, NET1 and NET2 trials, and then we have also more recently lutetium dotatate with compared to sunitinib in a small French trial, and a new somatostatin receptor targeted radiopharmaceutical with a different ligand, that is lutetium dotatate or lutetium dotatalk, that has proven in the COMPETE trial that improves progression-free survival versus everolimus. So now we have a number of trials that show that radioligand therapy may be better than targeted agents or high-dose somatostatin analogues in different settings. In terms of PFS, although no trial has demonstrated an overall survival benefit. In terms of sequence, we have also recently published the SECTOR trial. It's an investigator-initiated trial by Ramon Salazar and the GETNE Spanish group. That is the only sequence trial performed today in pancreatic NETs. It compares starting with everolimus and going to streptozotocin and 5-FU upon progression, or the opposite sequence. And what this trial shows is that in terms of PFS1 and PFS2, there are no major differences in terms of what you do first. No significant impact in overall survival or difference in overall survival between the two treatment sequences. Although chemotherapy, streptozotocin-based chemotherapy, is associated with a higher response rate, both in first and second line, 30%. So if tumor shrinkage is important, then chemotherapy may be a better option than a targeted agent. Now, what other factors do we have as predictive factors to choose? Very few. In terms of angiogenesis inhibitors, we have now evidence that in certain subgroups where angiogenesis is really the driver, and this is the case for VHL-related cancers, VHL-related pancreatic NETs, angiogenesis inhibitors can really be very effective. We have seen this with belzutifan with a 91% response rate versus only 10% if sporadic pan NETs. But we have some evidence also with other angiogenesis inhibitors, cabozantinib or sunitinib. And then some biomarkers in development, but not any other validated markers. And for chemotherapy, we have an important trial, again, an investigator-initiated trial by the French group, led by Thomas Walter, is the MGMT-NET trial that prospectively assess MGMT deficiency as a predictive marker for response to alkylating agents. And this trial stratified patients at baseline whether they were proficient or deficient in MGMT, and then randomized them in both cohorts to alkylating drugs or oxaliplatin-based chemotherapy. And the primary endpoint is not quite met, but they show higher response rate and improved PFS and overall survival benefit for deficient MGMT tumors when treated with alkylating agents. And this, but there's also other ongoing trials. Basically, the greatest development is being done in the field of radioligand therapy. With the development of new alpha emitters like actinium dotatate or lead-212 dotamtate of mTOR. So there are also other trials comparing lutetium dotatate or lutetium dotatalk versus everolimus in lung nets. This is important because radioligand therapy is not yet approved for lung nets. And then we have also the COMPOSE trial comparing lutetium dotatalk versus chemotherapy or other standard of care in G2 high, G3 low GEP-NETs. And these are going to be very important trials. And regarding targeted therapy, probably the most relevant trial in the NET field is the Stellar 311 trial comparing a new angiogenesis inhibitor, zanzalintinib, versus everolimus for these patients.